Good morning, everyone, and happy Tuesday. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar entitled Understanding and Challenging Barriers to Substance Use Treatment When Counseling People of Color with Gabriela Zapata-Alma. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and you will only be able to view your name. If you have questions, please send them to the presenter and the host by using the chat panel rather than the Q&A panel. The button to open the chat panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them, and the presenter will address them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen, and those options are also posted in the chat panel. If you continue to experience poor computer audio, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to both the audio of this presentation and be able to view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording, please go to www.fada.org, our Resource Center Training Library. And we do have a link with the materials posted in the chat panel this morning. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign into your account to complete the evaluation. You must complete a profile on the FADA website. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight on Monday, March 22nd. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And with that being said, I'd like to introduce our presenter today. Gabriela Zapata-Alma is the Director of Policy and Practice for Domestic Violence and Substance Use at the National Center for Domestic Violence, Trauma, and Mental Health, as well as faculty at the University of Chicago. Gabriela brings 15 years of experience working with people living with HIV/AIDS, impacted by housing instability, substance use disorders, and mental health conditions, as well as survivors of domestic violence and other trauma, providing direct services, training, advocacy, and consultation, and leading programs using a trauma-informed approach, motivational interviewing, harm reduction, gender responsive care, housing first, and third wave behavioral interventions. Gabriela has provided technical assistance through SAMHSA and other national leaders and best practices. Gabriela has also been recognized with numerous awards, including Health and Medicine Policy Research Group's 2018 Health Award and the Illinois Association of Addiction Professionals chapter of NADAAC's 2017 Rising Star Award. Gabriela has provided training and technical assistance relating to serving marginalized communities impacted by trauma and other detriments of health locally, nationally, and internationally. And now I would like to welcome our presenter, Gabriela. I will turn the presentation over to you. Thank you.
Thank you so much. Thanks everyone for joining us today. It's such a pleasure to be here with you today. I know it can be really hard to carve out this time, so I'm so glad that we have this time together. And thank you to the Florida Department of Children and Families and FADA for hosting this training and for inviting me to share this information. And so I see folks are coming in from sunny Florida. If you can send some of that sunshine my way, I'll be very, very grateful. And so here is my contact information. If there's anything that would be good to follow up on as we go through the information today, please feel free to reach out to me. I'm a licensed clinical social worker and, oh, you can't hear me. Let's see what that is about. Can folks hear me?
Yeah, I can hear you. And it looks like that might be an isolated incident. Maybe they need to turn their volume up or make sure they have speakers.
Okay.
Yeah.
Great. Thank you so much. And if you are having any trouble, please feel free to write in the chat or the Q&A, and we'll do our best to help troubleshoot with you. And so I forgot what I was saying. But anywho, it's so great to be here with y'all today. And another thing that I do is that I also lead the Alcohol and Other Drug Counselor Training Program at the University of Chicago. So in that role, I have the honor and the privilege to help cultivate future substance use disorder treatment counselors. And I've also had a history of working with recovery coaches and peer-based recovery support and developing both teams of peer-based recovery support as well as integrating recovery coaches into treatment teams. And so that is a huge passion of mine. And so I want to give a special shout out and welcome to any peer-based recovery specialists who are joining us today as well. And so a little bit about our center, the National Center on Domestic Violence, Trauma, and Mental Health. We are a special issue resource center dedicated to addressing the intersection of domestic violence, trauma, substance use, and mental health. And so we have an array of training and technical assistance services and resources. We conduct research and evaluation, policy development and analysis, as well as public awareness. And here is my government disclaimer. The things I say don't necessarily represent the official views of the U.S. Department of Health and Human Services. And so at the center, our work is informed by and really rooted within this integrated framework. So everything that we do is rooted within survivor-defined approaches, that people are the experts on their own lives, that they know what they need, they know what is possible for them, they know where the healing starts, that all of this is rooted within physical and emotional safety, relationship and connection, and hope and resilience. And when we can truly understand the connection between substance use disorders, mental health conditions, and trauma, then we can understand that the services that we provide need to be the radical opposite of that trauma. They need to be empowering, they need to be a healing environment, they need to be trauma-informed, and they need to have an attention to human rights and social justice, as well as an awareness of and responsiveness to cultural, historical, and community context. So in our time today, we will be especially focused on those final pieces. So here are our learning objectives for this session. As a result of this session, our hope is that you'll be able to identify at least 3 unique risk factors or barriers that people of color face, that you will be prepared to contextualize symptoms of substance use disorders as coping responses that aid in self-protection and survival for individuals who are impacted by structural and interpersonal violence, and that you'll be able to identify at least 2 strategies for cultural adaptation of evidence-based interventions. So first, contextualizing substance use disorders for people of color. Here we're going to talk about unique risks and barriers, as well as symptoms as threat responses. So first, starting with the concept and the framework of recovery capital. So recovery capital is all of the internal and external resources that we have access to that aid us in our journey of recovery. And it tends to fall along these 4 major areas. Now, something that I want to invite folks to go ahead and put in the chat, and I'll read it out loud because I realize that folks can't necessarily see each other's chat, is that I want to hear from folks. How do structural and interpersonal violence impact these different areas of recovery capital for persons of color? So I'll say it again. How do experiences of structural violence and interpersonal violence impact access to these different areas of recovery capital for people of color? And I'll give you some time to think about that and respond. And while you do that, I'll say this. Recovery itself can be a concept that is not necessarily culturally universal, that there are many people of color who recovery might feel like, the concept of recovery might actually feel like not really the term that describes their experience. And so when I have been working in culturally specific communities, what I've heard from many community members over time is that, there are so many other concepts that feel so much more relevant, such as the concept of healing, such as the concept of just connecting with self and connecting with community, connecting with family. Really being able to fulfill one's role within one's community or within one's family. And so when we're using the language of recovery, one thing that becomes really important is understanding how even the concept of recovery itself might not be culturally relevant for every single person that you meet with. And so the importance of being able to listen deeply to how people describe their own experience, how they describe their own goals, and to be able to connect to the way that they frame their healing or their recovery. All right, so now I'm going to go to the chat and see what folks have offered in response to the question, how does structural and interpersonal violence impact recovery capital for people of color? So here I see it can increase a sense of isolation and hopelessness. Absolutely. It can be, that we know that healing and recovery it's a community thing, right? And that hope is a core aspect of recovery. And so absolutely experiences of structural violence and interpersonal violence can really increase isolation and hopelessness for people of color. Let's see, what else? Trust could be impacted. Absolutely. When we have experienced harm, betrayal, targeting on an individual level, on a societal level, a community level, on a generational level, that that trust is absolutely damaged because we have learned that it is not safe to trust. We have learned that in order to protect ourselves, we need to be very judicious and discerning with who we trust. And layer on top of that all of the experiences of microaggressions and discrimination that we can face in the very places and from the very people who we are supposed to be trusting to help us with some of our deepest goals and our deepest needs, right? Leads to blaming individuals rather than offering support or examining systemic causes. Absolutely, 100%. So often within the context of structural violence, there is also the messaging and the coding of victim blaming, where people who are subject to this targeting and subject to structural violence are then blamed for the effects of that structural violence, and rather than being offered support and looking at those systemic causes and addressing those upstream root systemic issues, right? The systemic racism, for example. Let's see, more stigma for speaking to social supports, a lack of resources for physical needs such as safe housing and financial resources, particularly in areas where there may be lower socioeconomic status for people of color. Yes, so there can be a lot of intersecting forms of stigma and discrimination, and the ways that people of color are held to different standards, and how there is this sense that, this reality that in order to survive, we have to be perfect, we have to be blameless, that we don't have the luxury of making mistakes and learning from them the way that our white counterparts do. And so the way that shows up many times is then in really compounding forms of discrimination and stigma that make it so difficult to access that anti-stigma community, those recovery role models, and it makes it so difficult to access help in general. And there's so many intersecting forms of barriers there. And then, of course, the ways that structural violence plays out in reduced access to safe housing, to financial resources, to basic needs, to responsive and affirming health care, right? We only have to look at the disproportionate rates of maternal and infant fatality for our Black community members to see so clearly the effects of structural racism on physical health. We only have to look at the way that COVID has impacted our communities to see in real time the disproportionate impacts of that structural racism and structural violence has on our physical health. So here we could just keep going, right? We could spend the whole 2 hours just unpacking all of the ways that structural violence and interpersonal violence impacts recovery capital for persons of color. I want to add a second question now. So when we're thinking about culturally specific sources of resilience, of connection, and of healing, what might be missing from what's listed on this slide? What might be some culturally specific sources of recovery capital that maybe aren't represented on this slide? And I'll state the question again as you think about it. So what might be some culturally specific sources of resilience, of connection, and healing that aren't represented on this slide? Thank you, Savannah and Heather. Spirituality of any kind, religious beliefs, church and faith communities, faith homes, extended family. Absolutely. Yes, the experience of faith. Ethnic and cultural practices. Yes, we have many culturally specific practices that are handed down through generations, the generational connection. And this can show up in a lot of different ways. This can be generational connections with the ways that we may be likely to cohabitate and have really kind of close connections within multi-generational households and families. This also connects to the ways that we can, that we are many times connecting to ancestors and connecting to future generations and becoming worthy ancestors and raising future ancestors. And so having a connection within ancestors that we have emerged from, as well as the ancestors to come. And so having kind of that deep ancestral connection and intergenerational connection. Teachers and positive work relationships, right? We're kind of that deep relational approaches that extend beyond some of those immediate family and intimate relationships. Food and cooking traditions and rituals. Yes. And then all that's been mentioned and the values of self-worth and self-importance. Yes, thanks so much, everyone. And everything we've talked about so far, we're gonna keep talking about it. So continue to put stuff in the chat and raise things as it comes up. So I am going to start highlighting some of the evidence around the unique risks and barriers. At the same time, I want to be really clear in that while there are so many threats and risks and barriers that people of color that we uniquely face, at the same time, we also have so much resilience, so much capacity to overcome and to thrive despite all of these highly aversive contexts. And so I also want to really keep front and center all of the strengths that we possess. So first, looking at collective trauma. And this definition comes from a collaboration with my workplace, the National Center on Domestic Violence, Trauma, and Mental Health, is in collaboration with the National Indigenous Women's Resource Center. So collective trauma can be understood as cultural, historical, political, and economic trauma that impacts individuals and communities across generations. And so thinking about how does your practice, how does your program incorporate awareness of not only individual trauma in your trauma-informed approaches, but also collective trauma. And that without this awareness, it becomes, we are at a really high risk of re-traumatizing people by blaming individuals for collective trauma, historical trauma, and systemic structural violence, right? Racial trauma. Understanding that discrimination is a salient risk factor for substance use disorders. So in addition to dismantling systemic racism, we also need additional insight into the mediators and moderators of the effects of racial trauma. And so there's some evidence here that suggests that parent-child attachment and supportive parenting can help, is a protective factors for addressing the impact of discrimination as a risk factor for substance use disorder. And so here we really need to be thinking about the disproportionate impact of family separation on communities of color. And we need to be thinking about how are we counteracting that reality? How are we supporting parent-child attachment and family unification? And then also we have all of this science around allostatic load. And allostatic load is the cumulative burden of chronic stress and life events that shows up in our bodies and is linked with a variety of health conditions: cardiovascular health, metabolic health, inflammatory conditions, and that these have all been found higher among Black, Indigenous, and persons of color who experience discrimination. So this contributes to a higher risk for health conditions, which also increases the risk for substance use disorders, as well as complications from substance use in general. So whether or not somebody is using substances to the point where they meet criteria for a substance use disorder, they are still at higher risk for adverse health outcomes from substance use. And so there are some different tools for assessing racial trauma that have been developed and tested, but more research is needed to see if these tools can actually be used to improve clinical outcomes. So we know that there are some tools that can help us be more aware of the level of racial trauma, but we don't yet know whether they actually make a difference in in improving somebody's clinical outcomes. Some other resources that might be helpful here is an article called More Than Skin Deep: The Stress, Neurobiology, and Mental Health Consequences of Racial Discrimination. There's also another article called Health Risk Behaviors and Allostatic Load, a Systematic Review. And both of those, I have a long list of references and resources at the end of the slides. So please be sure to look through all of those if you want to find any additional articles and resources. There's also migration trauma. And so migration trauma, there are 4 different points in the migration experience that present a heightened risk for experiencing trauma. Pre-migration, so all of the conditions that lead a person or a family to migrating, that many times there are many kind of traumatizing conditions. Then the potential for trauma during transit, so during the actual transition from one place to another. Then upon arrival in that new place, then all of the conditions and barriers and threats to well-being and safety that are found in that new place. And then the final stage, the settlement stage, that here we see trauma showing up in multiple different ways potentially. One is potentially the experience of being a racial minority or having a racially targeted identity for the first time, and having that kind of minority stress and that experience of discrimination, racial discrimination potentially for the first time. Also, the feeling, all the microaggressions and discrimination of just, it doesn't kind of matter what you do or how long you've been here, kind of constantly getting the message that you are perpetually not welcome, you don't belong, that, even if you've lived here, 50 years, you're still a foreigner, et cetera. And then also all of the disconnection from family, from sources of meaning, from really where there can be a feeling feeling like a fish out of water, feeling like just a total shock of things being so different, so new. There can also be the experience of all of the things that were hoped for, potentially idealized, that were really driving the migration experience, come to find out that the reality is different in the settlement experience. And so there can also be a loss of ideals and a loss of a sense of kind of hopelessness, that all the things that I was really working for, all the things that I was moving towards, all the things that made all of this hardship worth it are actually not the case, are actually not here. The opportunities I was seeking, the safety I was seeking, right, is actually not the reality. And how that kind of hardship and that loss of ideals can be traumatizing. Absolutely. And so we see both an interrupted access to protective factors, so interrupted access to economic resources, access to health services, social support, parent-child attachment, etc. Interrupted attachment to cultural traditions and sources of support and healing. And then also see increased stress, including increased trauma risk factors, health disparities, social isolation, and then being blamed for hardship. And what we see, what the science has found, what the research has found, is that acculturation is actually correlated with increased substance use concerns. And so the thought, kind of the theory underlying that, explaining that evidence, is that it's that disconnection from those cultural sources of resilience, of healing, of meaning, those ethnic sources of pride, which then create a situation for substance use disorder risk to really increase. So as we think about some of the unique realities of people who come from families with migration experiences, we really need to be thinking about what are the experiences of migration trauma, what are the different experiences of acculturation within the family, and what is the impact that that's having within the family, and how is that showing up potentially in the substance use concern. And so a lot of what I did when I provided substance use disorder treatment was that I actually offered family therapy for Spanish-based family therapy for families that had kind of acculturation stress within the family, and that was really leading to the substance use concern. And so this is where we need to have an awareness of this piece in order to provide really relevant and responsive services. And then, of course, there's ACEs, the adverse childhood experiences. And so by now, a lot of people are aware of the impacts of adverse childhood experiences on the risk for developing different kinds of physical health conditions, mental health conditions, and substance use concerns. So that experiences such as childhood physical abuse, sexual abuse, emotional abuse, neglect, etc., are correlated with an increased risk for developing an alcohol use disorder, using substances intravenously, etc. So I want to build on that knowledge here, and I want to offer some things that aren't as widely known about ACEs. So the original ACE study all focused on adverse experiences within a household, and that study sample was almost 80% white respondents who were largely middle class. Now, there have been expanded community-level ACEs that were developed and tested in Philadelphia with a racially diverse sample. And they included the original ACEs, so the 10 kind of within household adverse childhood experiences, and added to them community-based adverse experiences, including witnessing violence, living in an unsafe neighborhood, experiences of bullying, living in poverty, and experiencing in a foster care placement. And what was found in these studies was that there was a higher rate of the conventional ACEs and much higher rate when including both the conventional and the expanded ACEs. And that there were some people who didn't experience any of the original ACEs and only experienced the community level ACEs. The community level ACEs were correlated with an increased risk of substance use disorder as well as HIV, but the risk factor there was actually poverty. That if somebody was living in poverty, then these expanded ACEs became a risk factor. If they were living it with socioeconomic stability, then that was a protective factor that addressed the other risk factors. So here again, highlighting that poverty is violence and poverty is human-made. Some more things to know about ACEs. So there are some limited studies looking at ACEs and health disparities in culturally specific groups, but the studies that do exist point to a disproportionate impact and burden on people of color. And time again, what's been found is that the higher rates of ACEs in people in communities of people of color can be directly connected to economic disenfranchisement. So again, pointing to structural violence and poverty as violence. So some more research. So Wells in this study found that Black and Latin American individuals were more likely to endorse structural barriers to treatment as opposed to their white counterparts who were more likely to say that they didn't need treatment. And so there was actually a high recognition of needing treatment among Black and Latin American individuals in this study. And what they cited was not being able to access treatment, that there was really increased wait times, and that there just wasn't treatment available to them, accessible to them in their community. So something to keep in mind is that if we're only focusing on insight-oriented therapies, if we're only focusing on, questions about whether somebody recognizes that they need treatment or not, that is not responsive to the reality of a lot of Black and Latin American individuals. Their reality is more so understanding a need, that they do have a need for services, but just not having the access to it. Or when we do have the access to it, then having experiences of discrimination and maltreatment by treatment staff, which then results, or I should say causes, dissatisfaction with services being unsafe, we're supposed to be doing healing work here, and yet what I'm experiencing is targeting, something that I experience every day in my life, going about my business anyways. So that's highly re-traumatizing. And then, of course, all of this then causes reduced treatment access, reduced engagement, reduced retention and completion of treatment, and reduced satisfaction and care, all of which are typically associated with poor long-term recovery outcomes. In addition, studies have also found that people of color are more likely to access mutual aid than formal treatment. So, for example, are more likely to access 12-step or access SMART recovery rather than access formal treatment. At the same time, it's also been found that people of color have lower rates of affiliation with mutual aid. Affiliation means actually feeling like part of the group, feeling like you're understood and that you have things in common and that you are creating bonds within the group. And we know that that affiliation is a core aspect of how mutual aid works, that affiliation is one of the core healing ingredients for why mutual aid works. So when we are, inviting people to try out different mutual aid groups, when we are offering mutual aid groups, we also need to think about how can we help people find mutual aid groups where they will have a better chance of feeling connected, of feeling understood, of creating those bonds. And so in our treatment services, as well as in our mutual aid groups, we need to actively focus on building cultures of anti-racism, of inclusivity, as well as having culturally specific resources such as the Wellbriety Recovery Circles for Native American individuals. So I mentioned economic disenfranchisement a little bit earlier, and I want to say a little more about that. So it has been found that people of color are uniquely impacted by barriers to employment and reduced income access. So there was this one study by Petrie that Black individuals who were being seen in substance use disorder treatment settings were found to experience more severe employment problems and at the same time had less severe alcohol use disorders, had less severe legal, family, social, and psychiatric difficulties than their white counterparts in this study. So, based on the results of this study, one potential conclusion is that a culturally specific treatment need could be that is responsive to structural violence and marginalization is having a focus on vocational services and vocational advocacy. So understanding that that needs may be different based on experiences of structural violence and how that plays out in everyday life. It's also been found when it comes to insurance coverage that there are really disproportionate barriers. So there's one national analysis that found that uninsured white individuals access specialty substance use disorder treatment 3 times more than uninsured people of color. And treatment deserts, communities that don't have accessible treatment options, and that many times treatment deserts can also be food deserts, pharmacy deserts, that these are really intersecting forms of oppression. And one study found that counties with higher proportions of Black residents and residents who were uninsured were also found to have less treatment programs that accepted public insurance or were publicly funded. So given all of these barriers to treatment access, how do people of color typically access specialty substance use disorder services? And it's not a good answer. Disproportionately, it is through the criminal legal system. People only having access once they are mandated through a criminal legal system. And we know that people of color, there's a whole lot of evidence here showing that people of color are much more likely to be met with punitive, criminalizing system responses rather than having access to healthcare services when it comes to our substance use. And that the harm isn't just the fact that now we're involved with a criminal legal system, which has all kinds of harms associated with it, but on top of that, the disproportionate criminal legal system involvement also contributes to health disparities, including higher rates of HIV. And that this isn't something that starts later in our adulthood. This is something that is happening from early adolescence. So looking at this one meta-analysis, this one large study of Black and Latin American youth as compared to their white counterparts, that Black and Latin American youth were much more likely to be referred to treatment through the criminal legal system, were much more likely to be mandated, were much more likely to only use cannabis and not use drugs intravenously. And yet, we're much more likely to be released from treatment with an unsatisfactory status, which we know is going to have, that has ripple effects across their trajectory and their access to resources. I also want to name a specific study that is a little bit dated at this point. It is from 1990, but we know that this is very much relevant still today. And so this study is from Chasnoff et al., and it was done in Florida. And it looked at the rates of mandated treatment referrals among pregnant women in Florida. And what it found was that drug testing, so toxicology tests, found no racial or ethnic differences in the actual use of alcohol or other drugs among these women. Nevertheless, Black women were 10 times more likely than white women to be reported to the authorities for court intervention and mandated treatment. So when we're talking about generational trauma and structural violence, we have to be really, really clear about how all of these systems interlock into a matrix of oppression that has generational impacts. Which brings us to a framework that can help us understand and contextualize substance use within all of these different threats and barriers. And this is the power threat meaning framework. And so this framework can also be used for mental health symptoms as well. And so rather than starting with a focus on just the individual and taking a very individualistic view, which a lot of our services, right, are kind of built on just focusing on the individual and just focusing on personal responsibility and personal accountability. And not to say that there's not a place for helping people to develop skills, to be able to work towards their goals, and that has some underpinnings with that personal accountability piece. Absolutely. But we can't just look at the individual. If we just look at the individual, then we're going to be missing all of these contextual factors, and it's going to be really easy for us to slip into blaming the individual for systemic harms. So within this context, where do we start? We start first by looking at what happened. How is power operating in this person's life? And here you see all these different forms of power. From there, we look at what was the impact? What kinds of threats does this pose? And we look at threats both to the individual, to the family, to the community, ideological threats, threats to their beliefs, threats to their knowledge and meaning, as well as bodily threats. right? Economic threats. So all the different ways that power shows up in these core threats. From there, we look at what sense do they make of it? What's the meaning of these experiences for them? And we can look at both the societal meaning, so kind of what is the threads of victim blaming in our society, what is the societal discourse around it, as well as what's the personal meaning. And this is really important to understand how the effects of discrimination and racism can be internalized, how for women of color, how internalized racism and internalized misogyny can be at play, right? And how those intersect. And then from there, we can consider risk factors, protective factors. And once we consider that whole picture, this is where we are now prepared to start thinking about the symptoms of a substance use disorder in their greater context as a threat response, as something that has truly helped someone to survive, right? And that when we can truly understand something as a threat response, then we can truly start to move out of victim blaming and just replicating structural violence in our services. And so thinking about intersectionality of race and gender. So here, I wanted to offer a systematic review by Redman et al. Of Black women's treatment barriers. And so I'm looking at just dozens of different studies that were done and looking for those themes. And these are some of the things that really rose to the top. Experiences of economic disenfranchisement as a form of structural violence that impacted their ability to access treatment. So things like inability to pay for treatment through insurance or income, barriers to transportation, childcare, experiencing long wait times, and of course being compounded by living in an area that had little access to treatment or other kinds of recovery resources. When it came to family support, family responsibilities and support, the family played a central role so that if the family supported or didn't support her going to treatment or her accessing to treatment, this was a salient factor. And so when we can move away from some of those individualistic approaches and have some of those more family and community-based and holistic approaches, that can be a really important move to address these unique barriers. Also, responsibilities of being a mother, of a wife, of a role within a family. And then, of course, the fear of negative interactions with child protective services and the fear of family separation. And I mean, as a mother myself, I can tell you that if there's anything in this world that could potentially threaten my connection with my child, I mean, that is so basic, that is so core, that is so fundamental, right? Then experiences of discrimination and maltreatment by staff. So unsurprisingly, this systematic review found time and time again that Black women preferred a Black woman therapist when possible, and that a lot of that had to do with the stereotyping they experienced and just the overt discrimination that they experienced, and that there can be both there can even be positive stereotyping that is very, very damaging, like the positive stereotype of this, quote, strong Black woman, right? And that is uniquely damaging because what it does is that it completely invalidates the hardship and the need for healing, right? Understanding that to tell someone or to assume that someone can always be strong is at the same time to say you are not worthy of having your pain tended to. It is incredibly invalidating. And then the lack of trauma-informed and trauma care services. And so here, the authors highlighted how a lot of these barriers impact women of all races and ethnicities. But for Black women, there's an added barrier of the structural violence resulting in economic disenfranchisement, reduced social capital, and increased scrutiny by systems such as CPS, and increased racial trauma, which then manifests in increased experiences of discrimination by staff and services. So it's not that Black women experience higher rates of intimate partner violence, for example, but all women living with substance use disorders are highly impacted by intimate partner violence and sexual violence. But women of color, on top of that, experience reduced access to resources that aid in safety, stability, and healing from intimate partner violence and sexual violence. And now thinking about the experience of girls and the gender-based violence to prison pipeline. And so this comes from a report that is called the Sexual Abuse to Prison Pipeline Report. And so looking at that girls are one of the fastest growing populations under correctional control, and that this disproportionately impacts girls of color. And I'm just going to name some of the labels on this chart here because I'm realizing that it's not very legible. So this is girls in residential correctional placement by race and ethnicity. And we see that Native American girls are the highest impacted, followed by African American girls, then followed by Hispanic. And so there's no evidence of increases in crime rates or violent crimes, and that this is largely due to the effects of trauma, including substance use. And we see that when we look at the ACEs, that 45% of girls in juvenile legal systems have 5 or more ACEs. We also know that girls' common reactions to trauma are criminalized and then exacerbated by the legal system. So the legal system isn't a source of healing. It's actually exacerbating the trauma symptoms, or exacerbating the trauma, which is then going to result in increased trauma symptoms and attempts at self-soothing, such as substance use. We also know that girls of color are more likely to be dually involved in child welfare and juvenile legal systems, which is associated with an increased risk of recidivism, of trauma, and of health disparities that persist into adulthood. So here, what we're really seeing is a pattern of survived and punished, and that these common experiences of high levels of surveillance and scrutiny by systems and low access to meaningful sources of support. And so I mentioned some of the data on intimate partner violence and substance use and mental health. And so I already mentioned this. I'm not going to spend a lot of time on it, but just in case you were wondering what I was talking about when I said that women with substance use disorders are highly impacted by intimate partner violence, sexual violence. Studies have found that half to 90% of women accessing substance use disorder treatment are impacted by intimate partner violence. And that intimate partner violence itself can be used as a tactic of abuse. So this is known as substance use coercion, and it's been found that women experiencing this kind of interpersonal violence will be, their treatment efforts will be sabotaged, their recovery efforts will be sabotaged by a partner seeking to exert power and control over them, and that many times they'll be introduced to substances by partners seeking to control or abuse them, or be forced to use substances. And one of the reasons I mention this right now is because in the national study that we did in partnership with the National Domestic Violence Hotline, women of color had much higher rates of experiencing substance use coercion And the group that was most highly disproportionately impacted were Native American women and Alaskan Native women. So trauma increases the risk of developing a substance use disorder. And then a substance use disorder increases a person's risk for being targeted by an abusive partner. And a big reason is because of stigma. Because stigma can be used to discredit people, to isolate them from sources of support, that people stop believing survivors when there's substance use involved. And then this is all further amplified in the context of structural violence, so that we can truly understand kind of how violence on the interpersonal level is a reflection of violence on the systemic level. And so we cannot address one without addressing the other. These are forever intertwined. So this is where accessible, culturally responsive, and trauma-informed approaches are really the bedrock or the foundation. And within this approach, an anti-racism approach, of course. And so just want to highlight our toolkit on accessible, culturally responsive, and trauma-informed approaches. We are getting close to our break time, so thanks for hanging with me. We will be taking our 5-minute break soon. So something I want to just talk about and hear from all of you before we go into that break. So despite all of the intersecting and interwoven risks and barriers that we just talked about, there's also evidence that suggests that people of color experience similar recovery outcomes. Despite all the barriers, despite the lack of treatment access, despite all the criminalization, despite all of the health disparities, despite all of the harm and discrimination faced in treatment, and dropping out of treatment early or having other kinds of barriers that don't allow them to complete, there's still evidence that people of color experience similar recovery outcomes. So why might that be? And so this points to the existence of culturally specific sources of resilience and healing. That's right, Carmen. Carmen just wrote in the chat, this could be because we are resilient, right? And so here it's important to think about how cultural adaptation can address a lot of these unique risks and barriers, as well as strengthen those long-term outcomes through including these cultural sources of strength and these culturally specific sources. So now I want to hear from all of you. How can we include culturally specific sources of health and of healing while avoiding cultural stereotyping and cultural appropriation? And I want to just, there's a little definition there of cultural appropriation in case that term, just helpful to have clarity around it. So how can we really include these unique, how can we tap into these unique culturally specific sources of healing, of health, of connection, while avoiding cultural stereotyping and appropriation? Hire more workers of color. Yes. Educating ourselves through supervision and training, learning from others. Yes, that place of cultural humility, of learner. Developing a greater awareness of culture. Asking clients respectful questions, so forming those respectful partnerships where we can learn about the ecosystem of culture from our clients. Learning from them, right? Because we don't want to be stereotyping and say, well, all Latin American people this, or all Black people that, or all, Asian people this. No, not at all, right? And so part of this work is being able to develop those strong partnerships with our clients that are characterized by respect, by deep listening, and by our learning from them as an ecosystem of culture. Compiling relevant resources and contacts in our area. Yes, educating employees on cultural sensitivity. Leveraging strengths born out of adversity. Yes, resilience is a superpower. We want to go beyond resilience and truly thrive, but resilience is a superpower. All right. Well, we'll review some models for developing culturally specific and culturally adapted practices that can mitigate the risk of stereotyping, appropriation, and other forms of cultural disruptiveness after our break. So if we could come back at 10 after. Thanks so much, everyone. everyone, welcome back. So now we're going to go ahead and get started on evidence-based practice and culturally responsive treatment. I'm going to start by just highlighting available evidence, including culturally specific evidence-based practices and cultural adaptation of evidence-based practices. So first, talking about some of the barriers to research evidence. So first off, a history of a lack of racially and ethnically diverse research samples. And this occurs for many reasons. One of them being the increased risk of complex barriers and concerns that are then set as exclusionary criteria for research. So for example, it's been found that there's been an overall pattern found that exclusionary criteria for research disproportionately excluded Black individuals, low-income individuals, and people who experience more severe alcohol or substance use disorders and more severe psychiatric conditions. On top of that, there is also a history of abuse and exploitation of people of color in research. And so very, very rightfully so, lack of trust with research. And even when there is diverse samples in research, outcomes are rarely reported by racial or ethnic identity. So for example, contingency management is considered to have a strong evidence base. But when outcomes were analyzed and reported according to race, as well as whether somebody was continuing to use substances at intake or had stopped using substances by the time that they had their intake, it was found that contingency management was not as effective for Black individuals who were using substances at treatment entry. And so even when there's racially diverse samples, we still don't necessarily know what the effectiveness is for that specific subgroup. And then there's also race and ethnic identity get categorized into really broad categories, which leads to kind of a homogenization. So thinking that all Latin American people are the same, or like all Black people are the same, and really misses the nuance within racial groups, as well as makes a lot of assumptions about what is kind of the most salient experience or identity. So an example of that is, so for example, Black and Latin American youth living in an urban setting may have more shared salient experiences than a Latin American young person living in an urban setting compared to a Latin American young person living in a rural setting. So this is where research the way that research is conducted and the way that racial and ethnic identities are categorized into these broad categories aren't necessarily helpful for understanding some of those nuanced experiences within groups. And so that can be a risk for stereotyping as well. There's also the potential for experimental research design methods to conflict with the values and priorities of culturally specific groups. So an example of this is, in experimental research, there is a high value placed on objectivity and a high value placed on, people not being kind of aware of the different conditions that they may be in the hopes of reducing the potential for bias in the research study. Now, in some culturally specific groups, that may really clash because that some of the values might be based on building really deep connections and relationships, and that trust might be built on really radical transparency. And so that might not be a good fit. So all of this points to the need for the expansion of participatory research, qualitative methods, strengths-based inquiry, as well as the inclusion of a diversity of ways of knowing, including lived experience, community wisdom, and ancestral wisdom. So now a quick review of evidence-based practices that do have diverse samples. And you have the citations here, as well as in the references if you want to look more closely. So seeking safety, diverse samples in regards to race, specifically Black, Latin American, only a small percent of Asian American, as well as diversity around gender, although does lean towards feminine identified. Helping women recover and beyond trauma. So both of these, both this and seeking safety are integrated treatment for substance use disorders and trauma. And then looking at cognitive behavioral therapy. Relapse prevention therapy, which is based on CBT, has been tested with 77% person of color sample. That said, mindfulness-based relapse prevention was found to be more effective for women of color when compared to traditional relapse prevention. So that may be an intervention that you may want to add on to your services if you're finding that women of color are not being retained in your services. That might be a potential option. And then also brief marijuana dependence counseling, which is a combination of CBT and motivational enhancement therapy. And the matrix model has also been tested with, both of these actually have been tested with a 52% racially diverse research sample. SAMHSA tip 59 here, there talks about how Maud and Griffin in their 1998 study compared CBT and 12-step facilitation for a group of mostly African-American men, with 80% African-American. These men were also experiencing homelessness. What was found was that CBT had significantly better outcomes compared to 12-step facilitation, except for those who considered themselves very religious. And then those who considered themselves very religious had better outcomes with 12-step facilitation. So just some things to keep in mind here. Also, one more thing about CBT is that a meta-analysis of CBT found that non-Hispanic white individuals had much better recovery outcomes with CBT compared to Black and Latin American individuals. So even if there is some evidence to point out effectiveness because of diverse research samples, we also have evidence that says that there is a need for cultural adaptation or potentially a completely different intervention. Now looking at motivational interviewing and motivational enhancement therapy. So there's been a lot of diverse samples including Black, Latin American, Native American, and Asian American samples. It's also been tested outside of the U.S. Now, the meta-analysis by Hedema raised questions of whether a culturally adapted motivational interviewing is needed, because despite there being diversity in the research samples, there's also an indication that additional cultural adaptation is beneficial, especially when addressing barriers to treatment access and completion of treatment in order to improve long-term recovery outcomes. Culturally adapted motivational interviewing and MET have been developed and tested with Latin American populations and Native American tribes in the Southwest, as well as Native American youth in urban settings. It has also been tested to a smaller degree for Black Americans, and that work was done by Longshore and Grills. And then it may present a deeper adaptation need for Asian American individuals. There's been some development, but not a whole lot of testing of adaptations for Asian Americans as well as South Asian individuals. There's also a manual with recommendations for culturally adapted expert screening, brief intervention, and referral to treatment, which is a highly evidence-based intervention and is based in motivational interviewing. Now looking specifically at young people. Here is a list of EBPs that have been tested with diverse samples. And so a lot of these, as you can see, are family focused. And one thing I'll add is that multisystemic family therapy has also been a recommended evidence-based practice for Black adults who have often been found to have more intact family relations and extended networks of support when compared to their white counterparts. And then looking at culturally specific interventions for youth. So these studies found that culturally sensitive interventions had much better effects. So that even though there are evidence-based practices that have been tested with racially diverse groups, that when the intervention is actually culturally specific, that it usually has even better effects. And so these interventions use both group there's both group interventions as well as individual and family formats. So some sessions would be individual and some sessions would be with family. And here are the different interventions that were included. Culturally accommodated cognitive behavioral therapy, structural ecosystem therapy, strategic family therapy, culturally informed and flexible family-based treatment for adolescents, multidimensional family therapy, adolescent portable therapy, and the Cherokee Talking Circles, which was developed by Kituwa Cherokee youth and led by a counselor and a cultural expert. And then culturally specific interventions for adults. So again, finding that culturally adapted evidence-based practices tend to have better results than unadapted evidence-based practices. And so while there's a lot more research needed, here is a list of promising interventions. And so one I want to highlight is Celebrating Families, Celebrando Familias. That is specifically for parents with infants and young children, and is available in English and Spanish, and has been culturally adapted for Latin American families, as well as culturally adapted for Native American families in collaboration with Wellbriety. And then another one that I will just point out is the Boston Consortium model. So this was collaboratively adapted to better meet the unique realities of women of color with low or no income, primarily in urban settings, and is available in English and in Spanish. There's one primary point of contact that provides support and coordination across services, and then there's 5 modules. This is built on TREM, Trauma Recovery and Empowerment Model. So it uses the TREM curriculum and has added sessions on HIV prevention, a peer-delivered Women's Leadership Training Institute, sessions on economic success and recovery, pathways to family reunification and recovery, and a nurturing program for families. And then now, I want to share some ways to approach adaptation of evidence-based practices. So for example, if you are using the matrix model, these are some different models that you could use to help adapt that matrix model to be even more culturally responsive for the people coming to your program. So the main reasons for cultural adaptation include when there are barriers to engagement, when there are unique risk or resilience factors, when there's unique symptoms of a common disorder, or when the unadapted program just isn't working for that particular group, or it would be so much more effective if it was adapted. So here's a visual for our visual learners in the room. And so I'm just going to talk through this because I also recognize that it can feel very busy. So the parts I'm going to talk through are the parts that have the kind of yellow-orange bubbles around them. So looking at ineffective engagement or barriers to engagement. First, outreach. Does the community recognize the provider as a potential source of assistance? So I remember my first job that I had a bilingual caseload, and I was providing bilingual and bicultural services. And one of the questions that kept coming up to me in my first year was like, why aren't there more people coming in for this service? Why aren't there more people taking advantage of their service? And I attended a conference. And one of the things that I learned in one of the workshops was, if your organization doesn't have their, outward-facing materials in Spanish, if you don't have a name that is also in Spanish or can also be understood in Spanish, then people aren't going to have any idea that you're offering a bilingual, bicultural service. And it was one of those aha moments in my life, like, oh my goodness. It took someone saying it to me, but once they said it to me, it was so clear. And so just thinking about, does the community even recognize the provider as a potential source of assistance? Then moving to access, are there organizational barriers such as language, right? Does somebody have to get all the way to a counselor to be able to find out that there's interpretation services, right? How are they going to get there if they don't know that that's available on the front end? So what are the language barriers? Are there barriers in the procedures or potentially in the environment to accessing services? I remember I was providing a training on intimate partner violence and substance use disorders. And one of the people in the audience said, we partner with law enforcement, and so a lot of people who are undocumented are afraid to come to us. And it was like, yeah, absolutely. That is the reality, right? And so are there any, and that part of the way that partnership was made clear was because they were actually co-located. And so thinking about, right, are there any environmental barriers to accessing the services as well as procedural and language barriers? When we're thinking about engagement and participation in treatment activities, if the client does make that initial contact, are they actually engaged with the program and with the provider? And then thinking about the ways that we define problems, needs, and goals. Can the person accessing the service and the person providing the service arrive at a mutually understandable and acceptable definition of the problem and the goal? Because if we aren't being person-centered, if we aren't connecting with that person's subjective reality, and we're trying to get them to if we're trying to convince them of what we think the problem is and what the goal should be, that is going to be a huge barrier to engagement. I remember speaking with a student who was starting some trauma therapy with somebody who had been through a refugee experience. And she said to me, the person's treatment goal is that, she just wants to have someone to talk to, and she'd like to make friends, And the counselor was having a hard time with how do I translate this goal into a trauma treatment goal, right? And that we had to talk together about what is culturally relevant for this person, right? What is meaningful for them? That something like quote unquote trauma therapy is not going to necessarily be meaningful or even necessarily feel safe for that person. But what is going to feel safe is the ability to craft a trusting relationship, the ability to connect with peers and with others and craft those trusting relationships. And that we know that those are core, fundamental pieces in establishing safety after trauma and healing from trauma, right? So it's not about us trying to convince someone of our problem definition. It's about us deeply understanding how somebody understands their needs, their life, their situation, And then it's really up to us to figure out how to translate that in a way that we can be helpful, as well as craft services that are aligned with those self-defined needs and resources. Then the acceptability of the intervention. So once the needs and the goals have been negotiated, is the intervention that's offered acceptable, right? Is it something that feels relevant, that feels helpful, that is aligned with their goals and with their experience? From there, we want to look at clients staying long enough to really get something out of the intervention. If not, then that's a huge, huge red flag that adaptation is needed. So that comes into looking at completion of treatment. Now looking at the unique risk or resilience factors. The certain groups exhibit different processes that influence the occurrence or course of the condition. So for example, understanding things like migration trauma. Are there specific experiences that really influence the ways that these kind of unique risk or resilience factors? And what are some of those unique protective and resilience factors, and can they or should they be included in treatment? So when we talked about the parent-child attachment as being protective against discrimination trauma, right, racialized trauma, how are our services supporting that protective factor? How are our services supporting parent-child attachment? Then looking at the unique symptoms of a common disorder. Here, it can be especially important to attend to any physical symptoms for potential somatization, that sometimes symptoms are felt more in the body, potentially, or expressed more in the body, and having a sense of the different ways that that things can show up. So for example, understanding the connection between acculturation, different levels of acculturation between a family, how that contributes to family dynamics and potentially family stress, and how all of that shows up in the development of a substance use disorder, and what would be important for the family in recovery from that substance use disorder. And then thinking about that non-significant intervention efficacy. So does the client respond to the intervention when the intervention is administered with fidelity? Now this of course assumes that the intervention is being delivered with fidelity. And so if that's something that you have questions about, there's certainly some different resources at FADA around that, including a recorded webinar that I actually did in last December of 2020. So all of this talks to kind of how to even think about whether adaptation is needed. So now we're going to talk about some of the ways that adaptation can be approached. So there can be top-down versus bottom-up approaches to adaptation. So top-down is an evidence-based practice that was developed for one group is modified for use with other groups. Now there are some potential critiques of the top-down approach. There can be the critique that there's an assumption that white is somehow neutral, that the experiences of white individuals can somehow form kind of the basis of an intervention. And that there's an assumption that all implicit bias can be detected and removed from an evidence-based practice, or even more potentially risky, that the evidence-based practice is bias-free. And that evidence-based practices that have been developed from Eurocentric cultures can continue to replicate existing oppression and oppressive structures. So these are all potential critiques of top-down approaches. And a bottom-up approach a practice is developed within the perspectives, values, histories, traditions, and realities of a group's specific cultural context. And here I've included an example of a bottom-up approach so that you can have a sense of what that can look like. And this comes from Sams's tip 59. The Ho'oponopono is a form of group therapy used by Native Hawaiians. It involves family members and is facilitated by a kupuna, an elder. So a qualitative study with pregnant or postpartum women with substance use disorders reported both high client satisfaction and positive outcomes. 80% were abstinent 2 years after treatment. So while evidence-based practice is very important, it's also important to recognize times where a bottom-up approach is going to be much more effective for people, for communities of color. Then there can be different levels of cultural adaptation. There can be surface level and then deep adaptation. So a surface level is changing an EBP's materials or activities in order to have it align with observable aspects of culture. So kind of the language, the music, the foods, the clothing. Deep structural adaptations are changed based on deeper cultural, social, historical, environmental, and psychological factors that influence health behaviors. So an example of a deep structure adaptation is that when a group came together globally to create the International Recovery Coaching Principles, they excluded the principle of empowerment and self-determination because there was no consensus on that being a defining aspect of recovery in the global context. And that speaks to some of the differences in cultures that are more oriented towards the collective. So we can think of these different levels of adaptation as an iceberg, kind of like the observable, the iceberg that you see above the water is, you know, those parts that you can kind of clearly, easily identify and see. And then those deep structure parts are the pieces that are much more, are not just easy to see on the surface, are things that we really come to learn through relationship and through centering the voices of people from the community and from different cultures. And then this here comes from a SAMHSA tip, and it talks about some promising practices and strategies for group therapy for African American women. And so I invite everyone to take a moment and just, you know, kind of glance through these and then name in the chat, what do you notice as some surface level adaptations? And what do you notice as some deep level adaptations? Remembering that surface level are things that are part of observable culture like clothing and food and music, language, and deep structure are things that are based on deeper cultural, social, historical, environmental, and psychological factors. And then I also, as you think about that, just want to point out some of the connections with structural violence and historical trauma here. So, for example, if feasible, limit group participation to African American women to enhance safety and comfort. So a big reason for that is because of the pervasive intersecting racism and misogyny that link into each other and then is felt across so many domains of the experience. And so really building safety by limiting the group to be culturally and gender specific. So we can see that as a direct response to experiences of structural violence and historical trauma. The last one on this list is also very clear how it is a direct response and counteracting of structural violence and historical trauma. And that is draw upon African American history as a foundation of recovery, using examples from the work of artists, writers, musicians, heroes, spiritual and political leaders, etc. Now, it is a manifestation of structural violence and historical trauma that our group curriculums wouldn't already have African American history and leaders as built into them, right? Kind of like the whitewashing of our education, of our history, and how all of that makes its way into what we cover in our groups, right? And here I see Zoe wrote in the chat, drawing upon history is a surface level adaptation. Yeah, so having some of those leaders and examples from African American history is absolutely surface level adaptation, and it's kind of the observable culture, and then how it responds to and counteracts structural violence also has some elements of being a deeper adaptation. So it's a little bit of both. All right. Thanks, folks. So now looking at a model for, oh, I saw one more come in now. The surface, using rituals, adapting language and history. Yes, deep. Promoting values, using meditation exercises, and incorporating spirituality and history. Yes, thank you so much. So now, going through the cultural accommodation model for substance use disorder treatment. And so here, this is a model that can be used whenever you want to formally adapt an evidence-based intervention to the community that you are serving. So the first stage is engaging community stakeholders, as well as looking at the published literature, looking at informed expert opinion, as well as having kind of a core team that is helping to pull all of this together. And so having focus groups, having an understanding of what are some of the themes coming from the literature, from the community stakeholders, from informed experts. And then from there, looking at both the treatment context, the treatment content and the treatment delivery to see what needs to be adapted in order to really be responsive to the cultural reality, as well as include and leverage cultural strengths and sources of meaning and resilience. From there, doing a small scale pilot, kind of making sure that it's making sense, and there aren't kind of in that, and having some idea of what changes might enhance it even more, and kind of taking the results from that initial piloting back to your group of community stakeholders, experts, and your internal team. And then from there, rolling it out more large scale across the program. And so here is an example of how they use this process. And so here, what they found that, and this was with Latin American youth, they found that family was a very large theme. And the sub-themes that they found from that was parental involvement and support, family dynamics and values, as well as some unique family risk factors. So when it came to the treatment content and delivery, some of the examples of adjustments they made was that the content, they had more role plays that included relevant family situations. And in the delivery, they increased contact with parents and adolescents through phone calls, mailing, and an initial parent meeting. You can kind of see how their process, what process they used, and then how they put that into action. And And then, as I mentioned, you know, there's also adaptation that may be needed specifically for survivors of intimate partner violence. And as we saw, that one of the main barriers found in that systemic review of barriers for Black women was the lack of trauma-informed care and trauma-specific services. And so we have found, based on our systematic review, that the following 5 elements can enhance an existing evidence-based practice that you're using to make it more responsive for survivors of intimate partner violence. First is just psychoeducation on intimate partner violence. The second is awareness of mental health coercion and substance use coercion and how sabotaging of recovery efforts can be part of that. Third is an attention to ongoing safety, including learning some, collaborating with people around supporting their safety. Fourth is cognitive and emotional coping skill development to address trauma-related symptoms and to support their goals. And then finally, a focus on survivor strengths, both their individual strengths as well as cultural strengths from which they can draw. Here's just a summary slide, of some key takeaways for our session today. Individual and collective trauma are risk factors for substance use disorders. People of color face unique risks and barriers due to the legacies of historical trauma and ongoing structural violence. Culturally specific sources of healing and resilience aid in recovery. Culturally responsive services are associated with better outcomes. And then, of course, many of the things that we can do to support culturally responsive substance use disorder treatment. And so it is through the work that we do within ourselves, within our programs, that we can transform the conditions that perpetuate violence. Always remembering that violence on the personal level is a reflection of violence on the structural level. And so with that, I want to be sure that folks have my contact information. I want to point out some of the different resources we have at our center. We have a whole page dedicated to resources for mental health and substance use treatment and recovery support providers. And there we have a guide that I've written on commitment to safety for all survivors. So it is a guide on how to support survivors who use substances. And then we also have a palm card on substance use coercion. So it's you can just print it out and have it on the clipboard or have it handy, and it can help just guide conversations around substance use coercion. Then we also have various materials on substance use coercion. We also have some materials on organizational trauma and how to really transform organizational trauma. And then I want to say thank you, of course. Thank you for our time together today. Thank you for all your contributions. And thank you, most importantly, for everything you do every day in service of healing, of recovery, of stability, and of really crafting a more just world. So with that, I want to open it up. We have a few minutes for questions before I hand it back to Karina.
Gabriela, I noticed a couple of questions. One is, how does biracial factor into these approaches?
Yes, so that is where we are always working with a culture of an ecosystem of a culture of one, or we never want to try to kind of just discreetly put people in categories. And so in that way, offering choices, offering options, and really partnering with each client, with each family, if we're providing family-based services, to get a sense of their, how they experience themselves, what are their own salient experiences and culture. It reminds me of, at times, having worked with a Latin American woman who also identified as a lesbian, And for her, her more kind of salient identity when it came to finding culturally specific services, she was much more interested in LGBTQ services. That felt like a much more relevant and safe space for her, right? And so that's where that respectful partnership of kind of deep empathy and connecting with people's subjective reality becomes very important. And also thinking about, when we're talking about some of the unique risk factors, that's where we can also consider, how is somebody kind of perceived and treated within the world. So, as myself, a multiracial person, I am a person who, I have Black ancestors. I don't typically read as Black, and so I don't tend to experience really ever anti-Black racism. That is an area of privilege that I hold. I tend to read much more as Latin American or Middle Eastern. And so understanding some of the ways that structural violence may be felt in that person's life, and that we will really only know that in conversation and in connection with that person when we're thinking about those unique risk factors and barriers. When it comes to culturally specific services, I would say that there are many people, if it's it really comes to how people identify, and so much of that is based in our upbringing, in our community, in our culture. And so again, really connecting with that person is that individual ecosystem of culture.
Thank you. We have one more question. Do you have resources for navigating when clients' cultures don't value therapy, insight-oriented emotional awareness, yet they are mandated to participate? It seems like another form of structural violence in a way.
Yeah, so there's certainly some resources kind of generally around the importance of engagement and building those trustworthy connections, particularly when somebody is being forced to engage in our service, is mandated to our service. And at the same time, I would say that it's really hard to pull apart how much of that is, the fact that somebody is mandated versus it being something that is around like a cultural norm. There's a saying in Spanish that even a piece of candy, if it's forced, tastes bitter. And so it's hard to kind of pull apart those two realities, I would say. I would also add that there are so many different sources of recovery, of healing. So really embracing those multiple pathways of recovery and understanding that the vast majority of people who do meet criteria for a substance use disorder recover without ever meeting a treatment professional. And so that's where I would say something that is within our power, something that we can do, right? We can't necessarily change the fact that this person's been mandated. We can't, right? We can focus on whatever that person finds meaningful. So I remember working with folks who had been mandated and, being able to say to them, being really clear on the limits of confidentiality. I report on, whether or not you are attending appointments with me. I don't report on, what we talk about during our sessions. So if you had, this amount of time each week to just focus on whatever you wanted to focus on, what would be the most, what would you use that time for? And a lot of times what I heard from people was, I want to have a better connection with my children. I want to focus on parenting. I'm doing some things as a parent that I don't want to do, that maybe my parents did, but I didn't like as a child, and I want to figure out a different way to parent. And so there were a lot of times that we had sessions and didn't talk about substance use at all. Because when we understand recovery capital, we understand that we can have a positive impact on recovery and have a whole session that doesn't talk about substance use, right? So having that truly trustworthy approach, really person-centered approach, and then holistic services. So, you know, maybe it's not the thing that feels like, quote, discrete treatment that feels like it's going to be a source of healing for this person. I remember talking with people and finding out from them that one of the most healing things in their experience was actually participating in activism. So that was the most healing thing for their trauma and for what they had experienced. So really embracing multiple pathways of healing, seeing what we can do to include services that would be more relevant and responsive. Would the person be interested in more somatic approaches, more movement-based approaches? Would the person be interested more in vocational support? I remember working with a lot of folks who were mandated that it was like, you know, once we talked about their goals just in general, and that they understood that we could just focus on vocational goals, the engagement completely changed. It was like, really, you're going to help me with that? Yes. And so that's where having really an array of options to choose from, really advocating for people, and then advocating for a really high level of confidentiality in their services so that we can provide services that are really tailored to their needs. And that all of that is going to have, if there is a substance use concern, all of that is going to have a positive impact on their recovery because of recovery capital. It's also going to have a positive impact on building trust. And so if and when some kind of, you know, insight-oriented therapy or more talk-based therapy, if they at some point decide to give that a try, or that that's something that could be useful, we are now a trusted person who takes them seriously, who believes in them, and who has offered some real tangible support. And so we're going to be the person they come to if and when they feel that that's important. And also that, like, there's, also one more thing, that there's so much healing that we can do that isn't just based in talk therapies, right? So, okay, I'll stop now.
So unfortunately, this is all the time that we have today. We did include the link in the chat panel that has all of the resources and the PowerPoint presentation. Gabriela, was there anything else that you needed to share before I move on?
You know, I just wanted to say thank you so much to everyone, and thank you so much, Karina, and just hand it back to you.
Okay. So we have included Gabriela's contact information so that you may contact her with any further questions you have. And Gabriela, we really thank you for all the work you put into this webinar and all the valuable information you shared with us today. We are sure this training will help practitioners better serve those struggling with disease of addiction. So thanks so much. A couple of items of business that we need to take care of real quick before we conclude. When we do conclude today's webinar, your browser will take you to an evaluation on VADA's website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation, and you can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license and prefix number the first time you register. After you sign in, you'll be directed onward to the evaluation. You may consider using the same email address you used when you registered for the webinar, and also when you set up your profile in VADA system. This helps us connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. In the next 15 minutes, the sender will be Messenger at WebEx And the evaluation will close at midnight on Monday, March the 22nd. We do not email statements of credit. So instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Again, we want to thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day and please hold for the evaluation. Thank you.